Dr. Baligai here. Today's podcast is on fluoropyrimidine cardiotoxicity. It's a primer for cardio-oncologists. I have two fascinating clinical vignettes, both of whom I saw in my practice. The first is a 78-year-old male who's a small business owner with a history of rectal cancer, coronary artery disease. He had two myocardial infarctions, and he had stents PCI done 6 years ago. And more recently, he had 6 stents inserted 6 weeks ago. He also has a history of dyslipidemia, type 2 diabetes, obstructive sleep apnea. He was admitted for a planned Flox chemotherapy. Flox is 5-fluorouracil, leucovorin, and oxaliplatin. This patient had been on capecitabine and oxaliplatin, that's Xelox. However, developed a STEMI and was admitted about 6 weeks ago, during which time 6 stents, 3 in the RCA, that's the right coronary artery, and 3 in the left circumflex. The decision was made to change chemotherapy to Flox with the first cycle inpatient after discussion with our cardio-oncology team. The second case was a 68-year-old male engineer with a past medical history for CAD. He had bypass grafting done 17 years ago, stents placed 3 years ago, and he had multiple PCIs, ischemic cardiomyopathy, chronic systolic heart failure, myocardial infarction, hypertension, dyslipidemia, obstructive sleep apnea, depression, type 2 diabetes, and GERD. A colonoscopy revealed an ulcerated, non-obstructing mass in the rectum, and biopsy came back as moderately differentiated adenocarcinoma. The patient was started on neoadjuvant chemotherapy with capecitabine 6 weeks ago. Upon starting capecitabine, he noticed intermittent worsening shortness of breath on exertion, right-sided jaw pain, which resolved with sublingual nitroglycerin, which he used 5 times a week. The right-sided jaw pain which he had was one of the cardinal symptoms he had before his myocardial infarct or myocardial ischemic events in the past. So with 5-FU, that is fluoropyrimidine cardiotoxicity, in the literature has been reported from 1 to 19%. Fluoropyrimidine are pyrimidine analogs that inhibit thymidine synthesis and DNA replication by inhibiting the enzyme thymidylate synthase, thereby attacking rapidly dividing solid tumors. While 5-FU is the third most common drug for the treatment of solid malignancies, it is the second most common drug associated with cardiotoxicity after anthracyclines in terms of the total number of patients who develop cardiotoxicity. The drug capecitabine is a prodrug for 5-FU, and both these medications are used in adenocarcinomas of the breast, adenocarcinomas and squamous cell carcinomas of the bladder, the GI tract, and the head and neck. It's particularly used commonly in advanced colorectal cancers. What are the cardiac effects of these drugs? Angina due to coronary vasospasm is the predominant manifestation. Other manifestations include myocardial infarction, like in our first patient, heart failure, cardiac arrhythmias, myocarditis, pericarditis, dissection of the coronary artery, QT prolongation, and even sudden death. What is the pathophysiology? The predominant pathophysiology is coronary vasospasm. It can result in direct myocardial toxicity, inflammation of the myocardium or myocarditis, direct toxicity to the endothelium of the coronary artery, resulting in thrombosis, increased reactive oxygen species in the myocardium and endothelium. Takotsubo cardiomyopathy has also been described due to an overdrive of the sympathetic system. It has been postulated that transformation of the RBC membrane can result in increased viscosity. And finally, an allergic kind of reaction resulting in the Conis syndrome. So these are all the pathophysiological mechanisms of fluoropyrimidine toxicity. Typically, it occurs in the first cycle of 5-fluoro infusions with the mean symptom onset of around 12 hours. Typically, no prior history of coronary artery disease. The ST depression or elevation resolves with resolution of chest pain. There could be a reduction in left ventricular ejection fraction on echo when compared to baseline. Patients often have a history of hypertension or may manifest with hypertension, have malaise, have cardiac arrhythmias, usually atrial arrhythmias, and even sudden death. The traditional risk factors for fluoropyrimidine cardiotoxicity include older age, concurrent use of other cardiotoxic agents, previous history of coronary artery disease, typical cardiovascular risk factors, continuous infusions versus bolus dosing. How do you diagnose these patients? They have typical symptoms of angina, accompanying EKG changes, cardiac biomarkers may be elevated, and changes in left ventricular ejection fraction from baseline, and changes on coronary angiography. Interestingly, there was a paper in the Journal of the American College of Cardiology, Cardio-Onc, from Tom Nealon's group, who in April of 21 published this paper, and they described 4,000 patients who received 5-fluorouracil over a 10-year period from 2009 to 2019, and they found that in this cohort, 87 patients had coronary vasospasm, and the mean age was 58 years in this group. Over 70% had greater than 1 cardiovascular risk factors. About a fourth were on beta blockers, and less than 5% or around 5% had calcium channel blocker use. Compared to patients without vasospasm, there were 174 patients, and the mean age was 64 years. About 85% had cardiovascular risk factors, more than 1 cardiovascular risk factors. About 40% were on beta blockers, and about 17% were on calcium channel blockers. So how does one approach these patients with 5-fluorouracil toxicity? The first step is to stop 5-FU therapy and treat them with aspirin, calcium channel blockers, and long-acting nitrates. Both these patients were fairly advanced with their rectal cancer, and the oncologist wanted to re-challenge them, but the re-challenging these patients increased the risk of death, myocardial infarction, and even development of cardiogenic shock. And this needs to be told to the patient because shared decision making before we re-challenge these patients. What are the recommendations for re-challenge? One is switching to a bolus regimen from continuous infusion. Second is pre-treatment with extended release nifedipine and isosorbide mononitrate about 3 to 4 hours prior to the 5-FU infusion. So they treat prior, then treat during the infusion with short-acting diltiazem and sublingual nitroglycerine as needed, and post-treatment with nifedipine and isosorbide mononitrate for 12 hours after the first dose of pre-treatment nitrate and calcium channel blockers. And it has been recommended that nifedipine been given for 24 hours post-treatment after the first dose. This is an adaptation from Joe Carver's work from UPenn. The other option is to use an antidote, Uridine Triacetate, which is a pyrimidine analog that competitively inhibits 5-FU incorporation. It was approved by the US FDA in 2015, and it is an antidote for severe fluorouracil toxicity, including cardiotoxicity. The first dose of uridine triacetate should be given within 96 hours of 5-FU toxicity and administered orally at 10 grams every 6 hours for 20 doses in adults. This is a regimen for treating 5-fluorouracil toxicity from Joe Carver's group at UPenn, published in the JACC Cardio-Onc 2020. Because of the concerns regarding recurrent vasospasm with continuous 5-fluorouracil and the oncological equipoise between bolus dosing and continuous infusion regimens, it's recommended switching patients from suspected coronary patients with suspected coronary vasospasm from FOLFOX to bolus dosing with FLOX. FLOX includes 5-FU, leucovorin, and oxaliplatin regimens. For patients with hypertension, it's recommended that blood pressure lowering medications, particularly calcium channel blockers, could be used. All patients should be pre-treated before the infusion, during the infusion, and after the infusion. Pre-treatment includes 30 to 60 milligrams of extended release nifedipine and 30 to 60 milligrams of isosorbate mononitrate 3 to 4 hours prior to chemotherapy. And of course, this dosing is dictated by blood pressure. Because 5-FU is preceded by infusion of leucovorin, it's recommended adding a second calcium blocker, 30 milligrams of short-acting oral diltiazem, at the start of infusion. The 5-FU bolus is delivered over a 12-minute period. For the first two re-challenges, it's important to maintain the presence of a physician or a nurse during the bolus and for 30 minutes subsequently to monitor status. Monitoring should continue for about an hour and a half, and patients may need to be reassessed by cardiology before discharging home. The recommended treatment by Joe Carver's group includes sublingual nitroglycerin and short-acting nifedipine sublingual. Both these medications should be available by the chairside for suspected coronary spasm. Once patients are at home following therapy, it's recommended that extended release nifedipine at a previous dosage after dinner and the next morning for a day be administered. Also, it's important routinely to check the patient's status the evening after the first cycle, and the patients need to be instructed to call with any symptom in the 36 hours following therapy. The pharmacokinetics for oral twice daily capecitabine is very similar to continuous infusion 5-FU. Oncologists typically treat 2 weeks on and 1 week off. During days 2 to 14 of the cycle, it's recommended to repeat pre-treatment with nifedipine and isosorbate mononitrate during the morning of the infusion. It's recommended using 90 milligrams of extended release diltiazem in the evening and 12 hours after the first dose. All patients should have nitroglycerin at hand. Patients should monitor the blood pressure daily and call the cardio-oncology team before taking any medication in the morning. In the absence of symptoms, capecitabine is continued, and because metabolites accumulate over 2 weeks, nifedipine and isosorbate mononitrate doses are up-titrated according to the systolic blood pressure to maintain a systolic blood pressure above 100 millimeters of mercury. On day 15 after the cycle completion, it's recommended that the nifedipine at day 14 dose as monotherapy for patients and only continue subsequent dosing for patients with high blood pressure. In patients with low systolic blood pressure, one is limited on medications to use on days 2 to 14 of the capecitabine cycle. It's very difficult to treat these patients. One may potentially use ranolazine, but there's not much data in the literature, particularly when the baseline blood pressure is low. All patients should receive education on cardiotoxicity treatment before treatment with reinforcement with every cycle. There have been instances where patients have had chest pain in the third cycle and have failed to call in. So they need to be encouraged to call in or even go to the emergency department if they have anginal symptoms. So what happened to our two patients? In the first patient, that 72-year-old male small business owner who had 6 stents placed following 5-FU therapy, the oncologist decided to re-challenge him. He received pre-treatment with extended release nifedipine and isosorbide mononitrate 3 to 4 hours prior to 5-FU infusion. He then received post-treatment nifedipine and isosorbide nitrate. He tolerated the infusion without any complications. On the morning of discharge, he denied any complaints. He was admitted overnight. The second patient who developed right side jaw pain, which was very similar to the symptoms of myocardial ischemia events which he had in the past. On his last visit to medical oncology, he was advised to stop taking the capecitabine, the Xeloda. He was holding the Xeloda and he was seen by cardio-oncology. He underwent cardiac cath. The left main was engaged, and he underwent balloon angioplasty to obstructive lesions in the ramus and the circumflex. It so happened that he resumed Xeloda without consulting the cardio-oncology team or his oncologist, but he reported no symptoms at all after his balloon angioplasty. So this is in a nutshell of our experience and approach to fluoropyrimidine cardiotoxicity. There are terrific expert analysis by Dr. Arti Asnani and Dr. Kanduri at acc.org, and 2 important papers, both in JACC Cardio-Onc, one by Joe Carver's group, titled How to Diagnose and Manage Patients with Fluoropyrimidine-Induced Chest Pain, a Single Center Approach, a must read. And the second one is a more recent one by Tom Nealon's group, which is titled The Incidence, Risk Factors and Outcomes with 5-fluorouracil associated coronary vasospasm.